For joining us. It is my pleasure today to introduce our speaker, Alison Hamilton, one of the fellows for What's New in Addictions Medicine. So Alison is a current addiction medicine fellow with a background in family medicine. Her firsthand experience with the gaps in addiction medicine care in rural areas inspired her to pursue further specialized training in addiction medicine. And so I'm happy to introduce Alison Hamilton for our talk today.
Thank you, Jesse. And hi, everyone. Today we're going to be talking about methadone for the treatment of fentanyl use disorder. First and foremost, just would like to respectfully acknowledge that I'm a humble guest on the unceded and stolen territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And I recognize that substance use disorders and discrimination against people who use drugs disproportionately harm Indigenous peoples, and that continued efforts are needed to dismantle ongoing colonial systems of oppression here on Turtle Island and all around the world. Have no conflicts of interest to declare. So our objectives for today, we're going to review the recent evidence, risks, and benefits of rapid methadone titration protocols. We're going to examine some of the trends and impacts on methadone treatment retention and discontinuation. And then we're going to explore some emerging and dynamic practices in methadone prescribing in the context of increasingly potent unregulated opioid supply. So to do this, we'll briefly go through some pharmacology and brief history of methadone. Going to quickly review some of the very established evidence for methadone, touch on the current guidelines with some recent updates, identify some knowledge gaps and some emerging evidence coming out to try to fill those. Then we have some examples of some community practice patterns and some suggestions for future practice directions. Just want to do a volume check at the back. Is the volume okay? Everyone can hear? Okay, thanks. So methadone, a long-acting synthetic opioid. It's got full mu opioid receptor agonism, some weak delta opioid receptor agonism, which has a role in reducing persistent pain, and then has some low affinity competitive antagonism of the NMDA receptor. This plays a bit of a role in opioid tolerance. It basically makes methadone gives it a lower risk of tolerance compared to some of the pure mu opioid receptors like morphine and fentanyl. It's got good oral bioavailability, reaches plasma concentration peaks at around 3 hours. And we know methadone has long and variable elimination half-life because it's a lipid-soluble molecule. So the average is 24 hours, but this has a very wide range from 8 to 120 hours. Because of this, it allows for daily dosing, making it a great opioid agonist therapy option. But it also means it requires careful titration because there can be some dose accumulation. And it can be quite difficult to standardize dose titrations because there's big variability between people. So there's no kind of one size fits all here. Just some quick kind of interesting history of methadone. So it was first formulated in 1939 in Germany. Basically, they were trying to replicate the core chemical structures of morphine and meperidine, knowing that they were strong anesthetics pain medications. And they ended up coming up with this structure, which they initially named amidone. They found that it was a strong analgesic. It was about 1 to 2 times more potent than morphine was their estimates. It had low euphoric effect, and it was a strong antitussive. So they originally actually planned to release it as an oral antitussant, but this was delayed due to the Second World War. So then after the Second World War, the Americans and British took control of the British lab, or the German labs, brought the research back home, and pharmaceutical companies began production. They renamed it from amidone based on the chemical compound of diphenyl methamino diphenylheptanone, which obviously naturally gets abbreviated to methadone. It was then approved for analgesic use in the US in 1947. In 1950, Dr. Maddox in Texas began using methadone as a substitution for morphine and heroin use disorders and was having some success. In 1959, Dr. Halliday here in Vancouver began to trial methadone for opioid withdrawal management, and then gradually shifted to using methadone for what he kind of called prolonged withdrawal, which ended up becoming opioid maintenance therapy, and drew the comparison between using opioid maintenance therapy for addiction and insulin treatment for diabetes, which I thought was cool to happen in the 60s. In 63, methadone maintenance was formally approved in British Columbia, and around the same time, the first clinic was opened in New York. And by the 60s and 70s, the first treatment programs were coming up in Ontario. In the 70s, there was 23 approved programs in Canada, and methadone became the first widely used opioid replacement therapy. In 2009, it was added to the WHO's essential list of medications. And more updated stats in the US in 2020, there was 300,000 people being prescribed methadone, and locally in British Columbia in 2023, there were 14,000 people. So it's of course one of our main first-line medications for opioid use disorder. Skip forward a couple years, we have what I think could best be described as oodles of evidence to support the use of methadone. Just going to summarize it quickly with two big reviews. So this is a systematic review that was published in the BMJ in 2017. Had 120, almost 123,000 participants that were on methadone over ranging from 1 to 14 years. Found that methadone reduced all-cause mortality rates from 36.1 in people who were not in treatment to 11.3 in people who were in treatment. So this is, of course, a reduction in an average of 25 fewer deaths per 1,000 person years. The orange arrows there are just highlighting the two average cohorts. Another systematic review, this one was published in JAMA Psychiatry in 2021, looked at 36 cohort studies with 750,000 people, found similar results that all-cause mortality while on any form of OAT, and they found this stable between methadone and buprenorphine, was 11 deaths per 1,000 person years, compared to all-cause mortality off of OAT was 23.97, and saw the same reduction for both methadone and buprenorphine. They also found that OAT was associated with lower risk of injury and poisoning, lower risk of suicide, cancer, alcohol-related, and cardiovascular-related mortality. So lots of benefits. But despite well-established efficacy, we know rates of methadone treatment discontinuation still remain quite high, especially in the initial weeks of treatment when the doses are being titrated. This is just a study to kind of illustrate that. This is data out of Nova Scotia on 1,800 participants in their OET programs. And they found significant rates of methadone discontinuation, up to 22% in the first 2 weeks of treatment, so very early on. And they found that their mean retention in methadone treatment was 101 days. Another study, this one's here in British Columbia, looked at population level data of patients receiving opioid agonist therapy from 2008 to 2018. They looked at 220,000 OAT episodes, but this was among 45,000 individuals. So that's an average of 4.8 OAT initiations per person in this program over this 10-year period. Just about 74% of those were methadone. And they found that 59% of methadone initiations completed the induction, which they defined as a 2-week period with no dose increases. And only 51% of methadone initiations actually reached 60 milligrams per day doses. And then this is a retrospective cohort study that was published in JAMA in 2024. They found, as part of the study, they were comparing buprenorphine to methadone, and this was done by many of our colleagues here. They found, as part of this, that the risk of methadone treatment discontinuation in the first 2 years, was 81.5%. So quite a high discontinuation rate over a long period, of course. And in this study, the median methadone treatment duration was 66 days, so also quite short. We do have some evidence that higher methadone doses seem to improve methadone treatment retention. This is a Cochrane review from 2003, found that methadone doses ranging from 60 to 100 milligrams are more effective at retaining patients and more effective at reducing both heroin and cocaine use, interestingly. Another meta-analysis, this one's from 2009, found greater retention with methadone doses above 60 milligrams per day. Also found greater retention with individualized flexible dose strategies as opposed to a fixed regimen for titration and maintenance. And then this is a study from 2009 here from British Columbia that found that average daily doses of greater than or equal to 120 milligrams per day were associated with longer treatment episodes. And they also found, as part of this study, that patients that had multiple treatment episodes, that as those episodes went along, they tended to get longer and longer time that they would stay in treatment with further episodes. This is a prospective study of patients on methadone who also reported using alcohol. They define this as just using alcohol once during the study period. So most of us might qualify for that. They were looking at factors associated with methadone retention and methadone discontinuation. So they found that daily heroin injection and homelessness were associated with methadone discontinuation. And they found methadone retention was associated with doses above 60 milligrams. Their median dose for patients that were retained, they found was 119 milligrams. Also positively associated with any other forms of substance use treatment, HCV seropositivity and HIV seropositivity. This study was published very recently. This is from February 2025. Again, from some of our colleagues here. Was a retrospective cohort study from here in Vancouver, looking at participants that were on methadone doses of at least 60 milligrams. And they asked them to self-report whether they felt their methadone dose was too low, just right, or too high. And then they were comparing that to the fentanyl positivity of urine drug screens, which they had 52% had fentanyl positive urine drug screens in this study. And they found that patients with fentanyl positive urine drug screens were significantly more likely to report that their methadone dose was too low compared to those with fentanyl and opioid negative urine drug screens. They didn't see a significant association for that in-between category of patients that had fentanyl negative but opioid positive urine drug screens. And they found no significant difference in the median methadone doses that these patients were receiving, which the median dose was 100 milligrams. One other observational study, this one is from Rhode Island. They were looking at the methadone doses required for people who were using fentanyl. And they found that in patients that achieved remission, they were on median doses of 100 milligrams, and their median time to remission was 64 days. So we've got some evidence that higher methadone doses improve treatment retention, particularly in those that are using fentanyl. And expert opinion generally is that people who use fentanyl frequently require doses over 100 milligrams, but we don't have a whole lot of evidence to explore this in further detail. But the question remains, how do we get patients to these methadone doses safely? So we have our guidelines that we follow, of course. As identifying methadone as a first-line treatment for opioid use disorder. So our guidelines through British Columbia is to start methadone up to 30 to 40 milligrams per day in patients with high tolerance and or past methadone experience, and then to titrate by 10 to 15 milligrams every 3 to 5 days in the unmonitored outpatient setting. Some Medify guidelines, these are out of Ontario. This was a recent update in 2021, excuse me, update with the goal of trying to kind of optimize things for fentanyl use. So they had increased at that time their starting dose to up to 30 milligrams. They kind of divided patient types into those that might qualify for faster titration, that higher end of 15 milligrams, basically people who are at lower risk of methadone toxicity, compared to those who would be better suited for slower titration, which they flagged risk factors such as older age, concomitant use of sedating medications or alcohol, being methadone naive, or being on high doses of benzos or alcohol. They also suggested that patients who had recently been on methadone, which they flagged as within the past week, could maybe be considered for faster dose increases, and then to slow that as the dose got above 75 to 80 milligrams. And then the American guidelines suggest initial doses of 10 to 30 milligrams. They also have kind of an extra second dose, not exceeding 10 milligrams on the first day if there's ongoing withdrawal symptoms. So that kind of works out to similar to the guidelines here, of 40 total in the first day. They suggest a slower titration, dose increases of 5 to 10 milligrams, no more frequently than every 7 days. So a little bit more cautious. And that the usual dosage range that would be needed is 60 to 120 milligrams. So if we're following these guidelines perfectly, and we've got kind of our treatment targets in mind that we've seen are better for retention, better for fentanyl use disorder, it would take at least 9 days to get to a stable dose of 60 milligrams. It would take 15 to 19 days to get to a stable dose of 100 milligrams. And it would take 21 or over 27 days to get to a stable dose of 120 milligrams. So we're taking quite a bit of time to get to these therapeutic targets. An interesting update out of the US, through the government, they amended their policy in February of last year to allow initial methadone doses of up to 50 milligrams or higher as clinically indicated. It was a little bit vague. This was the first big change to their opioid prescribing guidance in over 20 years. And there isn't really any further evidence out of the US yet in terms of whether this is something people are actually doing, whether this is maybe more of a legality litigation prevention strategy, or whether this is being used or not. The current guidelines, of course, are focusing on minimizing the risks of methadone toxicity, trying to prevent dose accumulation, trying to prevent oversedation. The cost of this is a delay, as we've seen, to achieving therapeutic methadone doses, which increases the risk of continued ongoing unregulated opioid use and increases the risk of treatment discontinuation. The reason for this is, the effects that we're worried about, of course, just to review quickly for everybody. Methadone is first and foremost an opioid. So it has the effects of opioid agonism, including respiratory depression and sedation being the most concerning. There's increased risk of toxicity with ongoing use of alcohol or sedative hypnotics. It's got complex and variable metabolism through cytochrome P450 system, and it's metabolized through the liver, and it's got a very long list of clinically significant drug interactions. It has a risk of QT prolongation. This is just to quantify the risk a little bit. A study out of Norway found that 4.6% of patients on methadone had QTC over 500. All of these patients were on doses above 120 milligrams. And they found as part of this cohort that the maximum mortality that they calculated was 0.06 per 100 patient years. And these were cases where they couldn't exclude QT prolongation as the cause of death, not necessarily caused by QT prolongation directly. Just a few notes on methadone tolerance. We know that cross-tolerance between methadone and other opioids, there is, of course, some cross-tolerance, but it's not fully predictable, and this is partially due to the weak NMDA antagonism. We've also seen that the tolerance to the respiratory depression of methadone happens after the tolerance to the euphoric effects, so this can be a little bit misleading sometimes, and the tolerance can be lost within a couple days. These guidelines that we've reviewed were mainly developed after there were multiple reports that came out in the 90s and early 2000s of some increased mortality in the early days of methadone initiation, and there was concerns for methadone-related deaths. Just kind of two quick reports to summarize these out of New South Wales. This first one was a review of methadone-related deaths in 1994. They reviewed 14 deaths with a forensic toxicologist, and they found at least 10 of them were deemed to be primarily caused directly by the toxic effects of methadone. One more was considered probable. If you ever want to put the fear of God into yourself, read through these specific case reports because they're a little scary. Oh, sorry. And so they determined that the rate of fatal iatrogenic methadone toxicity they estimated was 2.2 per 1,000 initiations at this time. I looked through these case details, as I mentioned, and kind of freaked myself out a little bit, but 5 patients, so 5 of the patient deaths had been receiving doses of 30 to 40 milligrams daily. 4 were receiving 50 to 65 milligrams, and the final 2 were receiving 75 and 110 milligrams. So not anywhere near what we would consider to be high or kind of scary methadone doses. All patients, they broke them down each really nicely, and all of them had either suspected reduced opioid tolerance, that there was maybe a period of time that they hadn't been using regularly, they had maybe been recently incarcerated and lost tolerance. Some of them, it was thought that they maybe were overrepresenting their use to gain access to the methadone. And then many also had concomitant benzodiazepine use confirmed on blood work postmortem. They also found many of the patients had displayed signs of methadone intoxication in the days before their death. Some of them had family members that were worried when they interviewed people. They found that they had been looking a little bit sleepy kind of in the days before that they had passed. And so their recommendation was that patients entering methadone treatment should be carefully informed of these risks and monitored very closely in the initial weeks of treatment. Another larger study out of New South Wales, this one included 238 patients who died while registered in methadone treatment from 1990 to 1995. They were coded based on coroner's data. So the deaths were coded as either drug-related, which would include methadone, medical illness, suicide, or trauma. They found 44% of the deaths were drug-related, and 24% were medical illness. And 50 of the deaths occurred in the first week of methadone, of which 88% were considered to be drug-related. So not inherently methadone-related, but including methadone-related. Their median starting dose of methadone, highlighted in orange there, was 40 milligrams. And the median range of their final dose was 45 milligrams, ranging higher, of course, but again, fairly low doses. They found only 4 patients had been prescribed doses of methadone that were in excess of the national clinical guidelines at that time. And the guidelines at that time were starting doses of 20 to 40 milligrams, maximum increases of 5 to 10 milligrams per day, with a maximum increase of 30 milligrams per week. So they determined that the mortality had been related to inadequate review of people's tolerance to methadone and or of people's use of other CNS depressants that had contributed to these deaths. So flags for kind of risk mitigation brought up by this evidence is the importance of course, a thorough substance use history, a frequent review of methadone tolerance, patient education on the risks of concomitant substance use during the time of methadone initiation, and regular clinical follow-up. So the majority of our literature on methadone involves patients who use heroin, and we know fentanyl, this range is very variable in the literature, but let's say 50 to 100 times more potent. We have seen higher doses of methadone are associated with increased retention and treatment, also with decreased unregulated use, particularly in the case of fentanyl use. We've got well-documented risks of methadone that are stable, but we have to balance these with increasing benefits in the context of potent and unregulated opioid supply, increasing rates of overdose. The benefits of methadone are kind of always increasing, so the math ends up being a little bit different now. And we've got evolving evidence and expert opinion on the best therapeutic dosage ranges for methadone. So we need more data to optimize methadone titration for people who are using fentanyl. One strategy for this has been to titrate methadone in the inpatient setting. Because we've got increased monitoring ability for signs of toxicity. We also have the ability to do flexible administration schedules, so we don't necessarily have to stick to once daily dosing. We can dose it multiple times throughout the day. Some potential disadvantages for this is some people are in hospital for a reason. So if they're acutely unwell, that's potentially kind of confounding or increasing their risk of methadone toxicity. Also, depending on what setting they're in, not to throw anyone under the bus, there might be other use of other sedating medications that could be changing their kind of tolerance overall. They've got a minimum stay of 5 to 7 days would be needed to kind of get to a steady state level, which is not feasible for everybody, not practical for everybody. And then just depending on the care setting, depending on everyone's comfort with titration, everyone's comfort with kind of monitoring for signs of toxicity determines whether this is kind of practical or not. But there's been some really great data coming out of these settings. So the first one was from our very own hospital here, from our colleagues. It was a case study, was what first kind of came out with this. Was a 36-year-old who was admitted for bacteremia, had a substance use history of using both heroin and crack cocaine, about 1 gram of each per day over the last 2 years, and was started on methadone at 30 milligrams with an additional 10 milligram doses available every 3 hours, up to 4 times a day. This might look familiar to lots of us. Received 60 milligrams on the first day. Don't know if you can see my mouse here. There we go. And then in that, going down that column was kind of the daily dose that was received by this patient each day. Maintained at a dose of 60 to 70 for most of the week. Noted no adverse events at 9 days, including a 9-day period of follow-up post-admission. And so this case study really highlighted the potential of an acute care setting to be able to initiate and rapidly titrate methadone for opioid use disorder. Then another study, this one came out in March 2023. This was a cohort of 25 patients in Baltimore. that was looking at a rapid methadone initiation protocol. So in this study, they excluded patients that had severe pulmonary disease, cirrhosis, end-stage renal disease, advanced congestive heart failure, and ventricular arrhythmias. They also suggested as part of their approach some relative contraindications, including age over 65, other medications that might affect methadone metabolism, and concurrent alcohol or benzo use in outpatient settings. Their protocol involves starting at 30 milligrams and then increasing by 10 milligrams daily until they reach 60 milligrams. So their average doses, the first day was 30, and then the average dose by day 5 was 61 milligrams. In the study, they found no major adverse events in hospital or 30 days follow-up post-discharge. They did have 2 instances of sedation, but said that neither of them led to holding of methadone doses. And they just also noted in their study population that 25% of patients had an alcohol use disorder and 29% of patients had a benzodiazepine use disorder. Another inpatient study, this one is out of Massachusetts General Hospital, looked at 112 patients with opioid use disorder who were initiated on methadone during admission by their AMCT team. They found that their mean initial daily methadone dose was 32 milligrams, ranging from 10 up to 90 milligrams on the first day. Their mean number of days to the peak was 5.6, ranging from 1 to 19 days. And then their mean maximum was 76.8 milligrams of methadone, also with a very big range up to 165. They had 4 safety events as part of the study that they deemed were probably or definitely related to methadone. All of them were sedation, was what was reported, and none required naloxone. They did a regression analysis as part of this, excuse me, and found that there was no significant difference in the methadone starting doses between the people that had sedation and those that didn't. And they found, unsurprisingly, that those with peak methadone doses above 100 had higher risk of sedation, a safety event. This is another St. Paul's study out of that was published in November 2023. Was a great review of patients that were initiated using the rapid methadone initiation protocol that we continue to use here. Their patient population, they noted some evidence of high opioid tolerance, including daily use of injection opioids, previous methadone prescriptions, and previous buprenorphine prescriptions. And they had, of the UDSs they were able to collect, 94% of them were positive for fentanyl on intake. So the protocol for this study, they used a standardized order set. They have an initial schedule starting dose of 30 to 40 milligrams. Then they would add on methadone PRN doses of 10 milligrams every 3 hours, limited to 3 this time. So that would work out to a maximum dose of 70 milligrams on day 1. They increase this every 3 to 5 days based on the cumulative use of PRN doses. So their mean doses on day 1 was 40 milligrams and then worked their way up to a mean of 6.5 milligrams on day 7. Just kind of a chart to show how this would work. This is from the POTS-B program. It was just a nice outline. Hopefully people are likely familiar with this because this is how we're currently doing it still. So if we started at 30 milligrams and then someone had available 3 extra 10 milligram PRNs, so that means their maximum dose on the first day could be up to 60 milligrams. That would stay the same for the first 3 days. If they were optimizing or maximizing out those PRNs and receiving 60 milligrams every day, that would then be consolidated on day 4 and also would be increased by 10 milligrams. So now their new morning dose is 70 milligrams. Then they continue to have those PRNs available. So now their maximum possible dose is 100. Again, on day 7, that gets consolidated to 110 and continues on. And so it was a very effective way to get doses up very quickly. You can see you can get up to a dose of 140 milligrams potentially by day 9. In review of the safety outcomes, they had sedation of 2 patients. 1 required naloxone administration, 1 required ICU transfer for observation. Both of these were felt to be maybe related to inappropriate patient selection. They felt that neither could be attributed just to methadone. There was kind of some other confounding factors. One had received some other sedating medications, and one had an acute medical illness. This just summarizes the cases, but more so wanted to highlight the doses they received. So the first patient, which is the one who was receiving some sedative medications, including loxapine and lorazepam, had just received 50 milligrams of methadone on the first day total and 50 milligrams on the second day. And then the second case was the one who had a medical illness, was admitted for sepsis, had received 60 milligrams of methadone on day 1, 80 milligrams the 2 days thereafter, and then it was held on the 4th day due to sedation. This is a study out of Portland looking at 25 patients. They were using a rapid methadone initiation protocol as well. In this study, they used exclusion criteria of end organ failure, arrhythmia, concurrent benzodiazepine or alcohol use, and age over 65. They sadly, UBC didn't give me access to the full article, so I couldn't get all of the protocol details for this one, but was able to get a summary of the maximum doses and the average doses that were used as part of the protocol. Just don't know kind of how it was broken down, if it was a single dose or if there was maybe some PRN use. So their maximum on day 1, the maximum doses could be as high as 60 milligrams, and the average dose was 53. And then that increased fairly quickly. By day 7, the maximum dose was 100, and what they actually saw was 96.6 milligrams. In this study, they found no adverse events that required a hold of methadone, no need for naloxone, and no need for transfer to a higher level of care. And then this is a study on pregnant patients with rapid inpatient methadone titration. This one's out of Philadelphia. They compared what they called a standard versus rapid titration protocols. I would argue there may be rapid versus rapider, which we'll see. So the standard titration, they had 97 patients in each cohort. The standard titration, they started with initial doses of 30 milligrams. They then added extra doses of 10 milligrams every 6 hours, as long as the cows was above 9, to a daily maximum of 60 milligrams. Then the following day, they consolidated that dose and continued with the additional 10 milligram PRNs. So quite a potentially rapid increase. And they considered patients to be at a stable methadone dose when they'd gone 18 hours without receiving any additional doses. So that's their standard protocol. The rapid protocol, which also had 97 people, they started at a dose of 30 milligrams if the cows was above 9, or 40 milligrams if the cows was above 14. After 4 hours, then patients received either an extra 10 milligrams, depending on their cows, or 20 milligrams, and then again received 10 milligram doses every 4 hours, as long as the cows was above 9. So their maximum day 1 dose was 90 milligrams. And again, the total daily dose was consolidated the following day, and then additional 10 milligram doses were continued as needed. This one, very similar, they considered a stable dose when they went 12 hours without needing extra doses. They also just had kind of a special policy in place for anyone who had been on methadone prior to the admission or very recently. So if they'd had a methadone dose within 8 days prior to this admission, then they were started on 70% of their outpatient dose once they had a cows above 9, regardless of which cohort they were randomized to or assigned to. If their dose was more than 8 days ago, then it was kind of the same. They were started on 30 milligrams if the cows was 9, 40 milligrams if the cows was above 14. So they had their median stable methadone dose. They didn't see a significant difference between these two protocols, but it ranged kind of 100 to 130 milligrams. They also saw no difference in their median admission length, or the median time to stable dose was about 4 to 5 days. They did find that the rapid titration cohort had lower rates of self-discharge and fewer methadone-related readmissions. They did a subgroup analysis of the patients who had not had methadone before, and found that these effects were consistent. In terms of safety outcomes, they did have one patient in the rapid titration cohort that required naloxone. and they weren't able to provide any more details as part of the study as to what had happened, or if this person had been on methadone before, if there was concerns around tolerance, if there were other sedating medications. Just don't have that details, unfortunately. And then this is a case series. This is looking at rapid methadone in the outpatient setting. So this is a case series from 2006 of a clinic in the UK that was doing what they called methadone tolerance tests. So they reported on 141 of these tolerance tests in 121 patients. This was done in 95 to 2005. So the way they did their tolerance testing, they described in great detail, they described how they took a very careful substance use history, including past prescribed and unregulated methadone use, and tried to determine with the patient what dose the patient felt would hold them, what was kind of their safe optimum methadone dose, and then that's what they gave them. They expressed the importance of really careful patient education, informed consent, shared decision-making with the patient to really identify what this number was that they were going to use. But they ultimately started at that dose. So then the patient went to the pharmacy, received the witness dose, and then was asked to present to the clinic immediately afterwards for monitoring. So their test doses ranged anywhere from 20 to 150 milligrams that they were giving upfront. The average was 63, the median was 70 milligrams. And they had 23 patients that received doses of 100 milligrams or more. In patients who had never had methadone before, which they said was very uncommon in their patient population, they were always using doses of 40 milligrams or less. They weren't just letting them choose what they wanted. They had a few patients who left the program, only 10 of which left without kind of any further care arrangement. So they called this an 8% dropout range. They had no patients that showed any evidence of methadone toxicity and no methadone-related deaths. They did have 3 deaths from natural causes during the study, and they had 2 heroin-related deaths during the study period. But they said both of these patients had had methadone discontinued. One had been recently admitted in hospital for a prolonged admission and had the methadone tapered off, and the other one had been incarcerated recently, and so they hadn't been on methadone, so they deemed that those were not methadone-related deaths. And then this is the only other outpatient. Oh, I might have one more actually. This is one of the other few outpatient methadone studies. This one's out of San Francisco. Looked at their rapid methadone induction for 93 patients. This was done in 2022. They had, so basically their day 1 dose was 40 milligrams, day 2 dose was 60 milligrams, and then from day 3 to day 5, they increased to 80 milligrams. For people to be part of this protocol, they had to report daily fentanyl use, and they had to not currently be on methadone. And then they had some exclusion criteria kind of similar to some of the other studies. They excluded people over the age of 65. They excluded those with heart failure, end-stage renal disease, cirrhosis, and advanced pulmonary disease. And they emphasize as part of their protocol kind of shared decision-making with patients regarding whether they were going to start the rapid protocol or whether they would stick with kind of the standard guidelines, and then ongoing throughout the study, whether they were going to continue on the protocol or whether they were going to kind of slow things down and shift off on one of those between days 1 and 5. They also said they, of course, didn't offer this protocol if patients appeared sedated when they first presented. This just kind of shows their flow through their study, but basically they had 65 patients that completed this titration and were up to 80 milligrams by day 7. So the patients who completed the protocol, they found had an average dose of 40 milligrams higher on day 7 than those who didn't complete. So the average dose was 89 milligrams on day 7 compared to 49 milligrams. And they also found improved 30-day retention of 88% compared to 79%. They had 3 patients that opted to slow the pace of induction, but none of them reported sedation as the reason for that. And they found no episodes of oversedation, non-fatal overdose, or death. Just to go back to our mortality studies from the beginning, there's just some more important data to kind of tease out of these. So they had, as part of these cohort studies, they had 6 studies that had time interval analysis. So they were able to look at kind of time on methadone treatment and time off of methadone treatment and analyze the mortality as part of this. So they found an increased mortality, in the first 4 weeks of methadone treatment, they found that this was 11.4 compared to the remainder of treatment where they found 5.8 per 1,000 person years. They also found that this was highest in the first week, up to 37.4, and then very quickly kind of decreased over the weeks to get down to 6.4 by week 4. Important context for this is just to remember that the overall stats for this were that the mortality, all-cause mortality, was 11.3 per 1,000 person years for those in methadone treatment. So that actually works out to quite similar to those first 4 weeks, compared to 36 for patients out of treatment. Again, quite similar to that week 1. And the data that I wish was included in these graphs here, you can see the top one is those kind of first couple weeks of methadone treatment. The bottom one is out of methadone treatment. And the data that we don't have reported is the kind of the mortality right before starting methadone treatment compared to then the start to see what that change might be. They also found that all-cause mortality was increased in the first 2 weeks after discontinuing methadone, increased to 24.1 to 35 per 1,000 person years. So overall, they found increased all-cause mortality during methadone initiation and discontinuation were kind of these 2 high-risk periods with methadone treatment. The other big meta-analysis we talked about at the start had some similar findings. So they had 14 studies that had some time interval data, and they found a 2-fold increase, so quite similar, in all-cause mortality and in drug-related poisoning, also in the first 4 weeks of methadone treatment, and that's compared to the rest of time on OAT. And they saw that only in methadone. They didn't see that same change in the buprenorphine group. And then they found the remainder of time on OAT was the lowest mortality period overall. They also saw the increase in the first 4 weeks after OAT cessation. They saw this was about 6-fold, again, similar to the other study, and then decreased to about 2-fold for the remainder of the time off of OAT. The treatment cessation part here it was just OAT cessation. They weren't able to differentiate methadone versus buprenorphine, just because a lot of the studies were mixed. So this is likely quite blurry, but the orange arrows just show which studies were methadone only. And then there's one study that was buprenorphine only, and the remainder were mixed. So they just weren't able to clearly tease out an effect of methadone versus buprenorphine for this part. This also is a very kind of busy chart, but just want to highlight 2 things here. The first section is the first 4 weeks of the mortality in the first 4 weeks of treatment. The second section is the first 4 weeks after treatment. Just wanting to highlight kind of the broader range of mortality data in this. I won't bother with this in this group here. And then the first 4 weeks after discontinuation, the average mortalities are here compared to the broader average mortality here. So some inconsistency in data, maybe some population-specific effects happening here, or maybe some time-specific effects not kind of fully fleshed out in the study. So overall, seeing about 2-fold increase in all-cause mortality and drug-related poisoning in the first 4 weeks of methadone treatment. The causation hasn't been clearly established here, but nevertheless, it's an important fact for us to be keeping in mind, especially if we're talking about changing the way or kind of pushing methadone titrations a bit more rapidly. Signals the need for caution, particularly in that first week period where we know the mortality would be highest. Of course, this could be related to rapid loss in opioid tolerance, maybe related to ongoing use of unregulated opioids or other CNS depressants during that kind of titration phase when doses are being adjusted. Also seeing consistently in these 2 studies, a 6-fold increase in all-cause mortality in the first 4 weeks after treatment discontinuation. Seeing this increase, so we've got kind of 2 high-risk periods during methadone initiation and methadone discontinuation. So really highlights that kind of cycling in and out of treatment exposes patients to increased mortality risks on both ends of that. Just a note on patient selection, kind of collecting common exclusion criteria throughout these studies. One point is to consider methadone tolerance, overlapping with, but a little bit distinct from opioid tolerance, that they don't necessarily cross over 100%, considering someone's past experience with methadone. Some of the kind of common exclusion criteria for these studies were age over 65, severe kind of end organ failure, arrhythmias, and what was consistently kind of identified as high dose use of other sedating medications, not necessarily any use. And then some cautions, of course, if someone's on multiple QT prolonging meds, if they've got other interacting meds or factors that may affect their metabolism, and alcohol and benzodiazepine use in the outpatient setting. A little caveat to benzodiazepine use, kind of thinking of separating out intentional benzodiazepine use from benzodiazepine contamination. Generally, the consensus, as far as I've seen, is not to reduce methadone doses out of concern of benzo contamination. So just wanted to, I'm just going to check the time. Okay. Review a few community practice patterns just that I've come across in my fellowship so far, what people are doing actively and kind of what seems to be working. So the study we talked about at St. Paul's is kind of the standard right now, the order set that we use, where we start at 30 to 40 milligrams for patients that have high opioid tolerance and then have the extra 10 milligram PRNs. Another clinic I've been able to work at is Sheway Clinic in the downtown east side. So their current policy is to start at methadone at 30 milligrams for patients that have unknown opioid tolerance and up to 60 milligrams for patients that have known tolerance, including patients that are methadone naive, as long as they've got really clearly demonstrated opioid tolerance. Then the increasing patterns are pretty similar to the guidelines. And their dose reductions, if they've got kind of missed doses, sometimes they'll titrate up more rapidly. They might increase by 10 milligrams per day, as long as they're assessing someone regularly. Excuse me. Another clinic I've been able to work at is Columbia Street Clinic. So they have had some changes to their methadone practice over the last couple years. So in 2020, like many clinics, they were prescribing methadone at 40 milligrams a day with extra hydromorphone as kind of a safer supply and a bridging medication during the pandemic. In 2023, they found that this wasn't working very well for their patient population. And so they took kind of the morphine equivalents of their hydromorphone dose, converted that into methadone equivalents, and have been initiating methadone at 80 milligrams daily. They're doing this only in patients who have previously demonstrated methadone tolerance and who have very clear ongoing high opioid tolerance. So that's been their current practice for the last couple of years, which is actually the subject of my fellowship research project, is to do kind of a case series and look for safety outcomes related to this practice. Some potential future practice directions, just kind of thinking about that risk of cycling in and out of treatment, the high risk periods of mortality with methadone initiation and methadone discontinuation. In Canada, we've got the community-based pharmacy model for opioid agonist therapy with daily dispensing. So this could potentially be leveraged in the future to maybe facilitate methadone restarts and titrations, to have this kind of a collaborative approach with our pharmacy colleagues, to have some pharmacy-led or kind of collaboratively led dose titrations that don't necessarily need a clinic visit or an in-person assessment each time that we want to be increasing the dose every couple days. Just could be a potential strategy to reduce some barriers to accessing methadone treatment for people. So just a rapid kind of summary. Retention in methadone treatment is associated with significant reduction in overdose and all-cause mortality. We know increased methadone doses are required for fentanyl use disorder generally, and they're also associated with reduced opioid use, increased OAT retention. We've seen higher risk treatment periods that have documented clearly an increase in all-cause mortality during methadone initiation, particularly in the first week, and then those first couple weeks of treatment discontinuation. And cycling in and out of treatment then, of course, exposes patients to increased mortality risks, which highlights the importance of prioritizing treatment retention as part of our strategies. As far as kind of evidence for rapid methadone initiations. So it helps us reach the therapeutic level faster, improves patient engagement and retention, also gives increased agency for patients, kind of having a broader range of starting doses and titration protocols to work from, gives people a little bit more choice and agency over what doses they're being started at. Allows us to get to therapeutic doses faster, so that means fewer visits for titration, which reduces barriers overall. Of course, some associated risks of methadone toxicity and related adverse events. And then this risk that we've seen of increased all-cause and overdose mortality in the first 4 weeks of methadone initiation. So all of this kind of comes down to balancing the risks, as so many things in addiction medicine, balancing the risks of methadone-related adverse events with the risks of prolonging the time to therapeutic doses. So it's kind of balancing the risk of inaction versus the risk of action. Often, I think the harm of something we've done is a little bit more scary, at least for me personally, to the harm of something we haven't done, but both need to be considered and balanced carefully. Rapid titrations in the monitored inpatient setting appeared to be safe and practical when there's sufficient monitoring and resources. And there's ongoing research on the safety of rapid titrations in unmonitored outpatient settings. And then just to highlight the importance of appropriate patient selection in the context of dynamic, highly variable supply, in the context of variable methadone metabolism and tolerance, there's really no one size fits all approach for methadone titration here. And these are my references. And thank you for listening.
Thank you so much, Alison, for that talk. Maybe what we'll do now is open the floor to some questions. Or any online as well.
Thank you.
Quick question, Columbia Street Clinic, the one you're doing there. You mentioned they start at 80 milligrams if they have previous, I don't remember if it was exposure or tolerance to methadone. What is that defined as?
Fair. So the question is about the Columbia Street policy, which I'm just going to scan the room to see if any of our staff from Columbia Street Clinic are here, or maybe someone's online, about the kind of caveat for starting at that 80 milligrams, defining the past methadone tolerance. I am not 100% sure. As far as I saw in kind of the policy, it was any methadone tolerance. Yeah. And then very clear ongoing high opioid tolerance was the other piece of that. Yeah. But very happy to be corrected if anyone has more details on that. Yeah.
Retrospective study from Nova Scotia comparing the methadone and buprenorphine. Do you had cited the rate of methadone discontinuation at like 22.2 within the first 2 weeks of treatment? How did that compare to the buprenorphine?
Sorry, I'm trying to find that. Oh, in that study, I think that one was only on methadone. That study the question was out of Nova Scotia on methadone retention in the first 2 weeks, which they cited at 20, or discontinuation was 22%. And how that compared to buprenorphine. I don't believe they compared it in that study. There have been a few recent studies, which I left out just because there was so much to cover here, that have shown methadone having improved retention compared to buprenorphine. Yeah. Fairly slight improved, but still significantly improved retention with methadone compared to buprenorphine. And I think in general, there's been some evidence for improved kind of patient satisfaction with methadone as well. Yeah. Great. Oh yeah, we do have some Columbia Street staff clarifying the policy so that typically it's the last 3 months at 80 milligrams or higher for the methadone exposure. Thank you, Lindsay. And then with daily fentanyl use as high opioid tolerance. Yeah. And there's a question here asking on behalf of nurse prescribing colleagues around the safety and outcomes where stable doses of methadone are quite high. High dose prescribing is out of scope for nurse prescribers. I'm not sure I understand the question there, Andrew. Do you mean asking whether stable doses of methadone, high stable doses of methadone would be safe for nurse prescribing? Is that the question?
Hi, can you hear me?
Oh, yes.
Yeah, just asking, so thinking of patients oftentimes in smaller communities where they're getting quite high doses, 150, 200 milligrams per day, like really high. that makes nurse prescribers quite nervous, especially if they're covering for the physician who's prescribing that high. So what does kind of the evidence and guidelines say for the sustained safety of these really high doses for people where there's higher risks for instability, like coming off, missing doses, stuff like that?
Yeah, great question. I would say all of the safety data, most of the safety analysis, certainly from what I saw, was kind of that methadone initiation or discontinuation phase. Certainly in those 2 mortality studies, the overall change in mortality was significantly decreased during the time on methadone on average compared to the time off of methadone. And so it's really those kind of initial titration periods when the doses are increasing, and those first 4 weeks after initiation were the highest risk time on methadone treatment. Otherwise, the stable time when someone's at a stable dose out of that 4-week period, that was considered the lowest mortality risk overall, including time on methadone and time off of methadone. So I guess I would say that someone who's on a very high dose of methadone but has been at a stable dose for some time, they would be considered, based on the data, as the lowest risk of mortality from methadones. Hopefully that answers your question. Oh, I got a thumbs up. Okay. Any other questions? Yeah.
I don't know if it was looked into any of the goal lines, but any of the data was based on rural communities or was the data?
So the question is whether much of this data was based out of rural communities or if it was primarily urban. I would say it seemed to be primarily urban. It was a lot of kind of urban hospitals with kind of consulting addiction services generally. Yeah, which is why I kind of wanted to highlight the resources, because it's sometimes is easy to say this works great and we should all be doing this, but doesn't necessarily translate to every setting. Yeah, definitely. Because certainly kind of comfort with monitoring for side effects of methadone, comfort kind of doing frequent dosing, comfort in general, just administering these high doses is key, because if the team isn't comfortable, then there's some safety concerns in general. Yeah, great question. Oh. So question in the chat says, wondering if you have any ideas for rapid methadone titration protocols for inpatients that don't involve PRN methadone doses. Because in interior health, there's some logistical kind of problems with PRN doses. Definitely some of the studies looked at kind of increasing the daily doses without PRN. So I do think that is potentially feasible. The advantage, of course, of the inpatient setting is that there's people around monitoring very closely. There's naloxone right nearby. So I think there still certainly is potential for an approach like that. It works nicely, of course, to do the PRN doses because you can time them kind of after methadone has reached its peak effect. So theoretically, you're minimizing the risk of sedation, but of course the dose is still accumulating. So I think still very possible to do it with daily dose increases, as was done in some of the studies. Any other questions? It is exactly 1 o'clock. Thanks, guys.